Okay, hi everyone. I wanted to give a quick little introduction to Unit 10, and that's cardiac implantable electronic devices. So cardiac implantable electronic devices. Implantable. Okay. Sorry, the whiteboard is so small. And under this umbrella of devices or electronic devices that are implanted, we are going to talk about pacemakers. And under that, we're going to talk about cardiac synchronization therapy. And then we're also going to look at implantable cardioverter defibrillators or ICDs. Most of the focus is going to be on permanent pacing, most of the focus of the unit, but you will see in your practice, you may see some of these other therapies in some of your patient population. Okay, in terms of pacemakers, we have temporary and permanent. Temporary pacemakers are transvenous. Transcutaneous pads. Okay, and sometimes you can have epicardial leads placed on the surface of the heart during surgery. But just so that you understand that these are temporary pacing scenarios in urgent and emergent situations. This is when we float guide wires up through a femoral artery. These are pacing pads that are placed on top of the chest, and it's like, in a code where someone's bradycardic, when we're putting pacing pads on the chest to pace across the skin. And like I said, these leads are placed temporarily on the surface of the heart in open heart surgery. So most of our focus is going to be in permanent pacing for the unit. And one thing that I want you to kind of get aware of or understand is that in terms of the leads of a pacemaker, okay, the leads are threaded through into the vena cava, and they're either attached here in the atrium, or they're threaded through, attached here in the ventricle. And then for resynchronization therapy, sometimes we have a third lead that goes through the coronary sinus across the posterior aspect of the heart and attaches here. Okay, so those are the different possibilities of lead placement in terms of a permanent pacemaker. And pacemakers have several parts. So you have a pulse generator, and then you have, like I said, either 1, 2, or 3 lead system. So this is a pulse generator, and then these are your leads. Okay. Now, with respect to the leads, you can have unipolar leads, and they're negative here at the end, or you can have a lead that's bipolar. Okay. You can imagine then if you had, just so that this is negative and then this is positive. So electrons always flow, or electricity always flows from a negative to a positive pole. And so if you have a unipolar lead, what that translates into is the energy is delivered, but then it's grounded back what we call the can or the pulse generator because it's positively oriented. What this looks like on ECG is a large spike or an ECG, pacemaker artifact. When you have a bipolar lead, the stimulus is delivered here, and then the electricity is delivered here, and then the ground goes back to the positive node or pole of the electrode. So you end up having a smaller pacemaker artifact. Okay, so that's the difference then between a unipolar and bipolar leads. So if you have a pacemaker, and we talk about having, dual chamber, single chamber. Chamber just refers to the chamber of the heart where the pacemaker lead might be lying. And we might have just an atrial lead. So we'll have a single chamber pacemaker with an atrial lead. I'll put the pulse generator up here. And you have the lead into the heart here. So remember, your SA node is somewhere over here. So when the lead is inserted into the myocardium, it's either anchored with a coil, so it's twisted in, or some ends have like kind of an arrow type of shape, so you can see that it'll insert into the myocardium and then not be able to tug back. And then hopefully you get myocardium and scar tissue growing over the ends of those leads. And that's how it anchors it into the myocardium upon insertion. But if you have a stimulus that's delivered here, if you can imagine on ECG, so here's the tracing, you get a pacemaker spike. If it's in the atrium, the objective of this energy is to depolarize the atrium. While on ECG, depolarization of the atrium is a P wave. So if you have an effective stimulus from a pacemaker, you're going to get a P wave. Okay, and perhaps I can change the color of the pacing spike just so that you can see. Okay, so this is effective capture, and that's evidenced by the pacer spike immediately following will be the P wave. So that would be an atrial paced. Now, if I have a lead coming in and attaching, well, it doesn't really attach up there. I should draw that a little bit better. It comes down and it's a little bit deeper in the ventricle, in the right ventricle. And you can imagine if it stimulates here, you're going to get ECG tracing. Let's assume there's a P wave. You're going to get a pacer spike as it fires, followed by a QRS complex. And then I hope you're noticing here that in terms of the ventricular pacing spike or a V-paced QRS complex, notice that it's wider. So this is normal narrow, let's assume, because I don't have a graph behind here. But you'll see that the pacemaker artifact in the ventricle causes a wider QRS, which we saw in ventricular rhythms. Because if you consider this insertion point, consider that now to be your ectopic site for the ventricle. And so what happens when we have a rhythm coming out of an ectopic site in the ventricle is that we lose the efficiency of the conduction system and our QRS duration increases because the wave of depolarization is in an aberrant or an alternate pathway. So we're not following down the left and right bundle branches to the Purkinje system and having the wonderful depolarization under normal circumstance. It actually replicates an ectopic site in the ventricles somewhere. So then you could also have P wave QRS complex. So you can have a scenario where I have a dual chamber pacemaker. I should draw that a little bit better so that it doesn't look like it's my P wave. Where you would actually see pacing artifact. So I've paced the atrium. And then I'm also pacing the ventricle, and then I have the wide QRS complex. And so the concept you want to talk about here is capture. So if you capture the atrium, you'll have artifact followed by P wave. And if you capture the ventricle, you're going to have pacemaker artifact immediately followed by a wide QRS complex. If you see a spike here and there's some distance, there's no capture there. If you see a spike inside of there, there's no capture there. Similarly, if I see a spike here, there's no capture of the ventricle. So in terms of the definition or the concept of capture, you must have the pacing artifact immediately followed by whether that's the P wave or the QRS complex. Okay, we also talked about a third lead potentially going through the coronary sinus out the back, or the posterior aspect of the heart, and then inserting on the left ventricle. And when we have a third lead in the left ventricle, or we have two leads, one in the left ventricle and one in the right ventricle, this is for resynchronization therapy. And this is for someone who has heart failure and some sort of dyssynchrony between the ventricular contraction or depolarization. So the attempt here is to fire in such a way that both ventricles depolarize at the same time as in the normal conduction of the heart, right? In a normal heart. Okay. You can see if you had just one pacer spike, that in the right ventricle, then my right ventricle would depolarize, and then the wave of the propagation of the stimulus has to go across the septum and then into. So you can see that you'll have a longer QRS complex, but that the ventricles are not simultaneously contracting or depolarizing and then contracting, and therefore it's less efficient. Okay, so cardiac resynchronization therapy could look something if you see them. I mean, don't always see them, but you might see something a little closer to that. Okay, where you have two pacer spikes, but the attempt is to create this QRS complex, have two ectopic sites, and hopefully firing at the same time, and then narrowing or decreasing the duration of your QRS complex in order to replicate a more normal heart, and then restore proper function, symptom management in people with heart failure. Okay, so those are a few concepts to get you started. And again, we're going to focus a little bit more on pacemaker in the unit. So watch the videos, do a couple of the readings, and then I'll post another couple of hopefully helpful videos for the unit. But see if you can sink your teeth into timing intervals. And then also there's a naming code for pacemakers, so you see what the function. The code actually helps you determine what the function of the permanent pacemaker is doing. And then there's a bunch of definitions that you're going to have to know. And then I'll come back with another couple of videos to hopefully help. We'll talk a little bit about ICDs and CRT. Okay, thanks.